Hello, everyone. My name is Dr. Tom Mazahery. I'm an orthopedic spine surgeon at OrthoVirginia in our Reston office. I've been with this practice for about 18 years, going on 19 years now. I grew up here in Northern Virginia, and I did my undergrad and other education down in Virginia. And then I went to Chicago and Northwestern for my residency and Case Western for my fellowship in Cleveland. And I made it back here for my practice. So I've been in this area for about 20 years now, doing exclusively spine surgery. We did a live stream like this, a Facebook Live event, a couple years ago that talked about hip versus back pain. And it was very popular, and so I wanted to do one that was similar to talk about the other diagnostic dilemma that we have, neck versus shoulder pain. And so it could be very confusing. It could be very difficult to figure out, and patients oftentimes come in and they're frustrated because they've had treatments other places, and sometimes it's hard to get a straight answer until we kind of dig in a little deeper. And so we'll get into that a little bit of how do you tell if it's your neck that's causing your shoulder pain, or is it your shoulder that's causing your neck pain, or vice versa, or sometimes it's both. Sometimes it could be a combination of the two and involves a deeper dive sometimes. The problem is if you don't get the diagnosis right and you're treating the shoulder and this ends up being the neck, you're not going to get the results. You're not going to get the treatment results that you want. So finding the right diagnosis and getting you into the right treatment plan is the key part of this. And the earlier you do that, the sooner you can get you back to your life, your activities, pain relief, and getting you back to your function. So we'll start with a little bit of anatomy. The cervical spine, as shown in this model here, is made up of the neck, or the cervical spine is made up of 7 vertebrae and 8 nerves that come out of the sides. Inside the canal, there's a canal that this protects, is your spinal cord, and again, the nerves come out on the side. Each joint is made out of 3 different parts. One is a disc in the front, and 2 facet joints. So 2 facet joints on either side of the back of the neck, and 1 disc in front of the neck that provides for motion as well as protects the neural elements inside there. And each of these nerves have a little different function, and they present differently. Unfortunately, just like anything else, degenerative changes can happen here. And if degenerative changes happen, be it a disc herniation or bone spurs or facet cysts or anything that's coming out, if it touches the nerve, it can cause some severe pain. And those patients typically present with possibly neck pain, but most of the time they actually present with more radiating pain shooting down the arm. The shoulder, which is not far away, is actually a very, what we call unconstrained joint. So it's a ball and socket. It's like a golf ball being on a tee. And that tee, because it's very non-constrained, oftentimes, if you can imagine, the golf ball can fall off. And so there's ways the body has created in order to create a high range of motion versus your hip, which has low range of motion, and yet create stability. And the stability comes from deepening of the socket, the T, that's called the labrum. So the T would have a little bit of extra rim around it. And then your dynamic stabilizers are your muscles, the rotator cuff, a group of 4 muscles that go around the ball and literally suck the ball onto the tee. And that prevents the dislocations or the abnormal motion. But over time, especially with above head activities and aging and degeneration, the tendons can have tendonitis or inflammation or tearing. And all of that can cause pain also. So you have pain in the shoulder. The question is it my shoulder and some of those tendons that we just talked about, or is it my neck that's causing some of these issues? The classic findings, the classic book teachings are sometimes not what we see in clinic, but I'm going to tell you about the classic findings and what we typically see. So typically, a patient who has a pinched nerve, depends on which nerve is being pinched, has a pain in a little bit of different distribution. Most people who have a pinched nerve, it starts from the back of the neck and the pain goes into the shoulder blade area, typically not into the front of the neck. So the C3 nerve sometimes comes to the top of the ear and the back of the neck. The C4 nerve goes to where you would have possibly a shawl on your neck, on the sides of your neck, and into the shoulder blade. The C5 nerve, which is one of the more common ones, goes typically to the outside of the shoulder. This is one of our big diagnostic dilemmas. Is it a C5 nerve issue or is it a shoulder issue? Especially if there's weakness. So if someone comes in and has shoulder weakness, is it the C5 nerve that's getting pinched, or possibly the C6, depending on what weakness it is? Or is there a structural issue to one of the tendons and there's a tear that's making it harder to lift your arm up? So the continuum of brain, nerves coming out of your spinal cord to your nerves, and they innervate a muscle, and that muscle pulls on the tendon, and the tendon pulls a bone, and the question is, where is that dysfunction happening, that something is weak? The C6 nerve typically comes again to the shoulder blade, and it comes down to these two fingers. It typically goes to the bicep and goes to the index and the thumb. And that's worse typically with hyperextension of the neck and rotation to the side. And C7 nerve, again, another common one that's pinched, lower on the shoulder blade, down the triceps, possibly with some triceps weakness. And it typically goes to the middle finger. And if it goes to these two fingers, it's either the C8 nerve typically, or a lot of times it's a problem of the ulnar nerve from the shoulder. From the elbow. Shoulder pain presents typically with pain more in the front of the shoulder. So most of the time, pain in the back of the shoulder, not every time, but most of the time it comes from a pinched nerve. Pain in the front of the shoulder typically comes from either your biceps tendon having problems, or your rotator cuff having problems, or your capsule having problems, a problem called frozen shoulder or adhesive capsulitis. And so knowing that as the background, when we walk in to see a patient who comes in with neck and shoulder pain, first thing we do is, first of all, we're asking, what's the history? When did this start? Where is it going? How painful is it? What have they tried and how did they respond? In general, again, the person who has shoulder pathology, rotator cuff or adhesive capsulitis or biceps tendon or other things, they don't like doing things above their head. So if a patient says, it really hurts when I lift above my head, I can't put the dishes away in the cupboards, or I can't do any of the above head activities, that bothers me. That's usually a shoulder pathology. Versus a pinched nerve, all those nerves that we talked about, when I walk into a room and I see a patient sitting there like this, their position of comfort is putting my hand above my head. They walk like this. They talk to you like this. They drive like this. They sleep like this. This is a pinched nerve typically. It's called a shoulder abduction sign, and patients feel a lot better when they do above head activities. So this is better with a pinched nerve versus with rotator cuff issues, that hurts more. If someone can't move their arm, the question is can they not move it because of weakness? Can they not move it because of pain? Or is it because they have something that's blocking their motion? So I'm watching how they're holding their arm. Are they holding it close to their body? Or are they looking for positions of comfort? If someone tries to put their jacket on, and if you're trying to put your jacket on or your clothes on, and that really hurts you, that's usually a shoulder pathology, because again, that's motions of your shoulder. And if I go to examine you and I say, we start doing a neurologic exam, and I typically start with a C5. Let me see how strong your biceps are, your deltoids are. And a patient doesn't want to bring it up. They bring up asymmetrically one side versus another. It makes me think that there's possibly a shoulder issue, unless there's a weakness that's coming from the neck. And so watching for symmetry of how they're moving their arms makes a big difference in where the pathology is coming from. So once we're watching them, that's the observation of it, is how are they holding their arms? What's happening when they do certain things? And then we ask at things at home. What about it sleeping? Again, typically people with pinched nerves like to bring their neck forward. So they add a pillow or two or three, or they sleep on a recliner, because when they bring their neck forward, that takes the pressure off the nerve in most scenarios. Patients with a pinched nerve don't like to go up. The hyperextension of their neck exacerbates it. And rotating to the side that the nerve is pinched makes it worse. Versus patients who have rotator cuff pathology, they don't like to lay on that side. When they rotate in the bed, it wakes them up in the middle of the night when they have a full rotator cuff tear. And they rotate on that shoulder and they say, ow, that really hurts. So those are all little things that we're trying to get from the history of how is this bothering you. And typically, again, we're doing an exam, and part of the exam, we're looking at their neck range of motion. There's an exam called the Sperling's maneuver, and basically what we do is try to recreate what I just said. And so we have, when someone is bothering their neck and shoulder, we see if they hyperextend, lateral rotate, and I try to push on the head a little bit, and that pinches on the nerve. If that reproduces their arm symptoms, because I'm pinching that nerve even more, it's coming from the pinched nerve. If there's a thing called a squeeze arm test, basically if I go behind them and I squeeze in the middle of the biceps here and that produces pain, that's typically a pinched nerve. That's a very high sensitivity for that. When I take someone's arm and anytime I move it for them with passive range of motion, they have pain. And if their passive range of motion is limited, then we start thinking about frozen shoulder. And so if someone comes in with frozen shoulder, and I see this actually around menopause a lot. We see this in patients who have rotator cuff pathology and they didn't know about it. And so for whatever reason, and we saw it during times where people were getting the COVID vaccine and it was causing inflammation, or any vaccine, and it was causing some inflammation and causing some frozen shoulder. So also what's happened over the last several months or years, what other life events is happening, that makes a difference on what we're doing here. There's a test called a Neer test and a Hawkins test that's more specific for the shoulder. So if I bring your arm up and I move it down, and if you have pain more in the front of the shoulder, that's a rotator cuff pathology, either tendonitis, calcific tendonitis, where there's calcifications in the tendon, or some sort of bursitis. So there's some sort of inflammation that's happening that's causing those symptoms. People with neck issues, typically when I move their arm, they say, nope, that feels pretty good. I don't have any major issues. And then there's a test called a drop arm test, basically where you bring the arm out and you isolate what we call the supraspinatus, which is one of the rotator cuff tendons that often is the first one that tears. And if I were to push on that arm and I've isolated that muscle and that arm falls down, there's a dysfunction of that tendon. Is it torn, or is there the nerve that comes to it, the C6 nerve, is not functioning? We got to kind of figure that out. So let's say we've gone through the exam and I know what it is. Well, that's easy. If we know based on that exam, it's pretty clear. Pain in the back of the neck and to the shoulder blade, all the way down, you have triceps weakness. That's a C7 nerve issue. Let's say we come in and you say, oh, when I roll on at nighttime, it really hurts. And I do a positive Hawkins test and it really hurts. Then that's a shoulder issue. But a lot of times it's still not clear. So then what do we do? So obviously we look at x-rays and see what the x-rays show. So we get imaging modality. X-rays show, am I seeing bone spurs, severe disc degeneration, collapse? Do I see osteoarthritis in the shoulder? Do I see what we'll call proximal migration of the humeral head, which means that the rotator cuff is torn and sometimes are shifting in the shoulder? So we look at x-rays to kind of see which way that takes. And then if not, we can't figure out on x-rays, which oftentimes we can't, then we get MRIs. That's usually the next diagnostic thing that we get. MRIs are very inclusive for a diagnostic modality. It shows all the soft tissue, it shows the disc, it shows the bone spurs, it shows the nerves and the spinal cord. And so it gives you a much better understanding. Problem is, if you get an MRI of anybody above age 50 or 60 of their neck, most likely you're going to find some degenerative changes. Are those degenerative changes that I'm seeing consistent with your exam? That is the harder part of what we do. The surgeries are easy. The treatment options are easy. The hard part is figuring out the diagnosis. And are those degenerative changes, the black disc, the disc degenerations, the bone spurs, consistent with your symptoms? And if they are, great, we have the diagnosis. If it isn't, then do we work up the shoulder? Sometimes we get an ultrasound of the shoulder to see if there is a tendon tear. Sometimes we get an MRI of the shoulder. And if we still have issues, we can get some nerve testing. It's called the EMG, or nerve conduction velocities. We can do that in the office here at Wrestling. And basically, we isolate which nerves are angry, if any are angry. And then on top of that, one of the things we use often is as a diagnostic modality, as well as a therapeutic modality, we like injections. So if we inject the shoulder, if in my office I say, oh my God, your pain is worse when I move your arm, let me do an injection for you. And you do the injection, and all your neck pain goes away, and all your shoulder pain goes away, it's your shoulder. And so we numb up an area to see how you respond to that area. And you'd be shocked how many people have neck pain that's the trapezius muscle working overtime because your rotator cuff muscle doesn't work very well. And so it's a compensatory pain because of the original problem here. And vice versa. If you have a pinched nerve in your neck causing your shoulder pain, and I move your arm around and it doesn't bother you at all, we can send you to get some cortisone shots in the neck. Now that's a bigger deal. It has to be done under a live x-ray. We don't do that in the office. We send you to either a pain specialist or some of our colleagues who do that. And either under a live x-ray or other modalities, they'll put a needle in and they numb up the area. And if you say, wow, when you inject my neck, all my arm symptoms went away, we have our diagnosis. That's our treatment, and we have our treatment options. And let's say you've done everything, and now you know, if you know and you still haven't gotten better, then there's surgical modalities coming for the neck. And in the neck, we have great modalities of either disc replacement versus fusion. I've done a talk on that before. That's also on our Facebook Lives. You can look that up if you like. And they both have their pros and cons, but it's a great way. Most patients who have the surgery, even as an outpatient, can wake up and the arm pain is gone if it's coming from the neck. If it's coming from the shoulder, I get my shoulder colleagues involved and I ask them, and sometimes, literally yesterday, we had a patient who had both. And the patient saw me, saw one of my colleagues, and we collaborated. And we said, well, if the nerve's not working properly, we can't fix the fully torn rotator cuff. So we decompressed the nerves. She woke up and said, wow, 50% of her symptoms is better. But she still has some range of motion issues and some weakness. And so in 6 weeks from now, she's going to have her rotator cuff addressed by the shoulder specialist. So that's a big, broad overview. Obviously, this can go lots of nuances of where we take this. Overall, some of the takeaways is neck and shoulder pathology can be very hard to figure out. Oftentimes, if it's in the front of the shoulder and it hurts with above head activities, that's more the shoulder. If it's in the back of the neck and radiates all the way down with numbness and tingling down your hands, it's typically the neck. And neck pain can come from the shoulder and the shoulder pain can come from the neck. So finding that appropriate cause of it and finding it early so you can get in the proper treatment options is key to making sure that you're not having prolonged pain and get you back to your life. I'm going to pause there. I'm going to see if we can take some questions and kind of see where this and see if we can tease out some other things from our audience.
Thank you so much, Dr. Mazahery. We do have some questions. Our first one is, does age play a factor in diagnosing, or is it only symptoms?
Of course, age is a factor. You know, when someone is 20 years old and they come in with symptoms, we're thinking more at soft tissue disc herniation in the neck versus that same person with that same set of symptoms is probably having some arthritis that's causing the pinching of the nerves. So it is a factor, it is a big factor in what we're thinking about as the source of it. But still, is it the shoulder versus neck? We have to kind of go through the process. If it's a 20-year-old baseball pitcher, we're going to think of a very different rotator cuff pathology than when it's a 75-year-old person who doesn't use shoulder often. But they both can have shoulder pathology and they both can have rotator cuff pathology. So we can get to the same endpoint, but it does change how we think. And that's the story and the age and how we got there makes a huge difference in our diagnosis, of course.
Thank you. How do the pinched nerves cause weakness in your arm?
So nerves have multiple different components that patients present with. So the three main things to present with a pinched nerve is that they can either present with pain, numbness and tingling, or motor weakness. And some people have no pain at all, and they just present with a painless weakness. And that's actually a very hard thing to treat, because when someone comes in and has gross weakness of the arm and no pain, we get nervous that the longer we sit on that, the more likely it becomes permanent. What motivates patients is pain. What motivates doctors to fix quickly is the weakness, because we don't want to have permanent deficits. And so it all depends on that. And I want to back up a little bit. In the neck, you have nerves, but you also have the spinal cord. And so we didn't talk about the spinal cord much because the spinal cord itself doesn't have much pain fibers. And so patients can have a pinched spinal cord and have very little pain symptoms. Those patients, what we worry about is not part of the shoulder pathology, but they have problems with balance, they have problems with dexterity, they have neurologic deterioration over the years, and it's attributed to the spinal cord being compressed, not the nerves. And those patients oftentimes have very little symptoms until it's late in their neurologic deficits.
Thank you. If pain starts in the arm and then goes up towards the shoulder, is that also a pinched nerve?
It can be. Depends on where it starts and how it travels. I've had most patients tell me that probably 9 out of 10 tell me that it starts from the upper part, from the neck and the shoulder, and it does go all the way down. But there's some patients who say they feel that the sensation is that it's going up. And so in those patients, we worry more about a peripheral nerve, if it's a nerve problem, being compressed, like carpal tunnel syndrome from the wrist up, cubital tunnel syndrome, which is from the elbow up, or we worry about biceps pathology or other muscle tendinous issues. So it does change how we think about it, but certainly a pinched nerve can present as traveling up versus down.
Thank you. For these issues, what are some of the treatments? You don't have to go into detail, but just like would physical therapy help? Would acupuncture help?
So for neck pathology and pinched nerves that we're talking about, I would say probably 75 to 85% of people get better with conservative care. And conservative care ranges from giving the time, letting nature settle things down. Sometimes the inflammation settles down and the nerve calms down. That all depends on, is it a disc or a bone spur or other things, but it can calm down. Anti-inflammatories, Advil, Aleve, Motrin, things that will calm down the inflammation, possibly a steroid pack. Physical therapy helps tremendously with a lot of these things. And in physical therapy, each therapist has a little different modality. But one of the things I actually like is cervical traction. Not a huge fan in the lower back, but in the neck, it works very well because patients oftentimes, when they distract across that area, it can unpinch a nerve and they feel good for at least when they're in traction. The cortisone shots are a tremendous help. I think they help significantly, and most people can do up to 3 before we say no more. But most people kind of know after 1 or 2 shots. And then obviously if everything else fails, there's the surgical options to help.
Thank you. If somebody regularly feels like they have a crick in their neck, is that something that should be checked out?
Not necessarily. You should always talk to your doctor if there's any concern. But if you have stiffness or a crick in your neck by itself, without neurologic deficits, without any pain shooting all the way down your arms, without any neurologic weakness, and if the pain is not getting worse and it has good days and bad days, and your balance and dexterity isn't affected, and you're not dropping things with your hands, that you probably have some arthritis in your neck, or you probably have some inflammation, depending on the age group and the scenario. And that usually responds to, like we said, conservative measures, time, anti-inflammatory. So I would start with giving it some time. I would get your heart rate up. I think exercise is good. So any exercise that gets your heart rate up gets oxygen to the neck and back muscles. and kind of can flush out some of that inflammation. And so I would start with some of that and see how that feels. And if given a couple of days, a couple of weeks, a couple of months, and your symptoms are not getting better, then I would seek professional help by going to see the doctor and getting some x-rays and further evaluation.
All right. Thank you so much, Dr. Mazahery. If you have asked us a question while we were live, we will answer it later in the comments. Dr. Mazahery, would you like to close?
I appreciate everyone being here. Obviously, going back to the original discussion, this can be a very difficult diagnostic dilemma, but finding a doctor, be it a shoulder or a neck doctor, that can do a thorough physical and thorough evaluation of this will help get you diagnosed earlier and get you to the proper treatment options.